I'll be talking about four topics in a go. Diabetes, obesity, sarcopenia, and the stiff man. Now, diabetes and obesity are like twin brothers. They go hand in hand. And obesity and sarcopenia are twin devils. So, they are ominous for health, basically. Now, there is a muscle deficient obese stiff patient, which is called the stiff man, which is a clinical correlate with sarcopenic obesity. Now, stiff man is an obese individual with low mobility due to reduced muscle strength, and because of the obesity, your sarcopenia you are unable to pick up in a lot of cases. They may appear strong externally but exhibit poor gait, balance, and endurance. Sarcopenic obesity underlies the functional stiffness in many older diabetic patients. Now, what are the cause of stiffness in obese diabetic patients with sarcopenia? One is muscle fiber atrophy and muscle degeneration, which is a correlate of diabetes and aging, and this is accelerated by diabetes. Fat infiltration in the muscle increases mechanical resistance to movement. It is a mechanical barrier, and chronic low grade inflammation basically causes further sarcopenia, tendon fibrosis, and joint stiffness. So, muscle fatigue and impaired neuromuscular control sets in this setting. Also, there is a diabetic peripheral neuropathy, which basically leads to impairment of the neuromuscular signaling and muscle weakness. There is also altered proprioception, increased fall risk, gait changes, increased rigidity and stiffness. Tendinopathies, there is fibrosis at the level of tendons, basically. Tendons lose elasticity, especially Achilles, patellar, rotator cuff tendons, frozen shoulder, adhesive capsulitis, and limit limb mobility. Osteoarthritis and lumbar spondylitis are also there. So, all of this basically set in the stage for obese patient who is having poor gait, who is having his functional abilities restricted, he is wary of falling down, and all of this leads to a stiffness which is more of a precautionary. So, this is the stiff man syndrome, and this picture highlights the prayer sign where the hand joints and tendons have become stiff basically. Now, diabetes, you know that diabetes is rising, and by 2050 we will have 73% excess diabetic patients. Obesity, more than half the population of 4 years older will be obese by 2035. If you see the US obesity epidemic, the obesity rates are rising, and even in the children basically across both genders the obesity rates are rising. The same position exists in India where men, women, boys, girls, everybody is getting obese. In the Indian context, because we have less of muscle mass, 23 is the upper cutoff for BMI, 23 to 25 overweight, and beyond 25 is obesity. Abdominal obesity in Indian cutoff is less. Abdominal circumference, waist circumference more than 19 males and more than 18 females we consider as bad for metabolic health, and therefore we are the thin fat Indian phenotype. Now, there is a term which is the normal weight obesity, where even in the BMI of 18.5 to 23 you have excess fat, excess insulin resistance, excess chronic inflammation, and you have more propensity to have metabolic and cardiovascular risk in these subset of patients, and almost 30 to 40% of normal weight individuals in India are having normal weight obesity. We are genetically predisposed. Our muscle mass at birth is less. Indian women, particularly postmenopausal and sedentary, are at greater risk. These populations show rapid sarcopenia transition with minimal weight changes, and why we need to recognize this is that we have to intervene in these patients at an early stage to their benefit. Coming to sarcopenia, we are too much focused on macro and microvascular disease and weight loss, but sarcopenia remains largely neglected. Now, these are various studies about sarcopenia, which are now, it is a major focus of research. Now, we will see various terminologies. Lean muscle mass is the body weight minus the fat, and it has muscles, bones, water, connective tissue and organs. It reflects metabolic health, and it is an important thing for glucose disposal and insulin sensitivity. Then we have appendicular muscle mass, which is the muscle attached to the major bones basically, and it is closely associated with mobility and functional strength. We have fat mass index, we have fat free mass index, and visceral obesity. Visceral obesity is very, very important because anything beyond 7% basically augurs badly for metabolic health. Now coming to the skeletal muscle. Now skeletal muscle, there is the bone, then the muscle, then it comes to muscle fiber bundle, muscle fiber, myofibril and myofilaments. Now why this is important? Because sarcopenia is invariably associated with osteoporosis and osteopenia. So both of these go hand in hand. In the muscles we have type 1 muscle fibers which are responsible for long-term performance or for endurance performance, for aerobic activities. They are slow fibers basically, and mainly their major sources of energy are glucose and beta oxidation of fatty acids. The type 2 fibers are the fibers which give you the instant reaction. They are fast fibers. They take energy from the glucose and glycogen which is stored in the muscles, and as you age your type 2 fibers go down, and that is a hallmark of aging, and it should be our endeavor to preserve these type 2 fibers with exercise modalities. Now sarcopenia, there are three things: skeletal muscle mass, skeletal muscle strength and performance. And of these three things, skeletal muscle strength is most important. That should be the first criteria, followed by mass and performance. So any two out of three basically will diagnose sarcopenia. Now sarcopenia has been recognized as a disease by WHO basically, and sarcopenia affects gait, balance, overall ability to perform daily tasks, and can greatly impact quality of life. Now you can see these two individuals. This individual is a sarcopenic individual, and this is an endurance athlete basically. So marathoners have low muscle mass, but they have great muscle strength. So muscle strength is always to be taken consideration, and we should not solely rely on the muscle mass basically. Sarcopenia in diabetics is a hidden epidemic, 2 to 3 times higher sarcopenia prevalence in diabetics. Covert onset, there is a functional decline, frailty, higher mortality, often masked by obesity in Indian patients, underdiagnosed due to BMI-centric evaluations. That is why BMI is fallacious basically, and it should go more on the waist circumference and the body roundness index. Now this is typically a sarcopenic individual. You can see that he is having great difficulty in getting up. Now the impact of sarcopenia, nearly 25% of 65-year-old and nearly 60% of people more than 80 years have sarcopenia. Now this is the normal decline of muscle mass, 0.5 to 1 from 40 onwards, and 1 to 2% from 50 years onwards, and this is the accelerated decline which may be due to multiple factors which we'll discuss in the subsequent slides. Now in healthy young people we have 30% muscle, 20% adipose tissue and 10% bone basically. In seniors by age of more than 75 years, muscle mass physiologically declines to 15%, adipose tissue rise to 20%, bone declines to 80%. So it is a gradual process, but if it is accelerated, then you are in trouble. Now decreased strength, easily exhausted, walking slowly, losing interest in being active, and unintentional weight loss are all hallmarks of sarcopenia. Now this is a figure which describes everything. This is a muscle fiber, the neuromuscular connection. So anything from brain, right from stroke to the spinal cord, to the peripheral nerves, to the neuromuscular connection, if there is any disease, then the muscle fiber is going to get affected. The blood supply, in those who do not exercise regularly, you have decreased capillary supply to the muscle fiber, which affects the muscle fiber. This is the muscle stem cells basically, which are go down with mitochondrial dysfunction. If your autophagy is decreased, autophagy is the clearing of the old senescent tissues of the DNA basically, which is very important for longevity health. Increased inflammatory markers like the reactive oxygen, especially in a host of chemokines which destroy these muscle cells, leading to sarcopenia. And mTOR is the main signaling hormone for improvement of the muscle mass, the activity of which goes down basically with sarcopenia. This is another cell which is the fibroblast adipoprogenitor cell basically, and this, if it is activated more, basically leads to more fibrous formation. So this is how the muscle fiber longevity is there. And now if you have downregulation of hormones like testosterone growth hormone, which occurs with aging, then your muscle mass will be there. increased inflammation like all the chronic inflammatory diseases including diabetes will lead to accelerated decline in the muscle mass, chronic conditions, neurological conditions, bad genes, old age, gut dysbiosis, physical inactivity, disability, abdominal obesity and mitochondrial dysfunction. All of this leads to sarcopenia, and physical inactivity deserves special mention because hardly 1/5 of the Indian population does the recommended amount of physical activity. So the sarcopenia is made by insulin resistance, chronic inflammation, increased fat mass, aging, reactive oxygen species and poor lifestyle, which basically once the sarcopenia is there, the skeletal muscles are the major sink in which the glucose basically is utilized. If the sarcopenia is there, glucose utilization is less, hyperglycemia, more insulin resistance, more sarcopenia. So this is a vicious cycle basically. 80% of the postprandial sugars are utilized by the muscles basically. So this is a one condition exacerbates the other condition sort of thing. Once you develop sarcopenia, you have reduced physical activity, strength, mobility, disability, reduced independent living, more bone fractures, osteopenia, all-cause mortality goes up, reduced body protein reserves, stress incontinence, nutritional status goes down, microvascular disease, dementia, Alzheimer's disease, insulin resistance, reduced energy needs, reduced resting metabolic rate because the skeletal muscles consume majority of the glucose. So your resting metabolic rate also goes down. Everything exacerbates your metabolic conditions and the metabolic deterioration is there basically. So already we have seen that low muscle strength, low muscle quality and low physical performance, any two of the three should be there diagnosed. Now how we diagnose the muscle strength? That is by hand grip. It should be more than 27 in men and more than 16 kg in women in Indian guidelines. Muscle mass you can assess by DEXA, but you cannot have DEXA in all patients because it is costly, availability is a problem. So you take help of bioimpedance machine, which there is a weighing machine sort of thing for cheaper people, and you have a in-body analysis machine which costs around 9 to 10 lakhs, which gives you a more sophisticated analysis of muscle mass. Another third thing which you can do for muscle mass is the calf circumference. It should be more than 34 in men and more than 33 in women. Physical performance by gait speed, the speed should be more than 0.8 meters per second. You can have a 5 times chair stand test. Patient should be able to stand and sit 5 times is less than 20 seconds. You can have a 400-meter walk test, should be less than 6 minutes, and then you have a timed up and go and SBBP or various tests to assess the physical performance. So these have to be done for assessment of sarcopenia, and we have a questionnaire which is a SARCF questionnaire which the patient fills, and as per the numbers you get, you can diagnose sarcopenia. So sarcopenia diagnosis is predominantly clinical, time consuming, and therefore is not being practiced in day to day, but it should be practiced. We should train our staff basically, and all the high risk population should be screened for diagnosis. So if you have only decreased muscle strength, you have probable sarcopenia. Decreased muscle strength with decreased muscle quantity, it is diagnosed as sarcopenia, and if there is a decreased physical performance, it is severe sarcopenia. This is how it goes. Now sarcopenia should be differentiated from cachexia and malnutrition basically. In cachexia, all of these conditions may have low muscle, all of these have low muscle mass, but fat may be more in sarcopenia if it is a obesity and sarcopenia combined basically. Mechanisms age related, sometimes pathological in sarcopenia, but in cachexia it is generally disease related and pathological, and in cachexia you have increased basal metabolic rate, but in sarcopenia and malnutrition you can have decreased metabolic rate. So you should have you should differentiate between these conditions basically in your patients. Now sarcopenic obesity is a metabolic epidemic basically because sarcopenia and obesity frequently coexist. Body is getting excessively fat while losing its muscle mass. So it is an incognito condition as far as the sarcopenia is concerned, and you have to be very vigilant if you are to diagnose this condition. Diabetes is a major risk factor for sarcopenic obesity. Now epidemic of sarcopenic obesity, you can see 30% of global population is overweight or obese. The various studies have found out different figures for sarcopenic obesity basically, and you will see these figures one by one. This is a very big study basically by Madhur Verma et al. Basically 72,250 older adults, and they found the incidence of sarcopenia combined with obesity as 8.7%. But this does not take into consideration the normal weight obesity. Now this was another study basically by Yogesh M et al. Basically, but the number of participants are less, 750 basically, where they found that 40% patients had sarcopenic obesity. Now this is a trial basically of sarcopenic obesity epidemic, and this also found out around 25% incidence of sarcopenic obesity basically. So 11% incidence of sarcopenic. So various studies have found out different incidence of sarcopenic study, and this is because of the differing criteria they have used to diagnose sarcopenic obesity, because criteria are very vague basically. All the they have given a uniform definition of defining sarcopenia, but the problem is that with aging there is definite functional and muscle strength decline, and these definitions do not take into consideration the decline with aging. So sometimes you go to for simplicity to diagnose rather than complexity, because if you make the things too complex, then the things will be very difficult to diagnose. Now, pathophysiology and risk factors for sarcopenic obesity development. We have unhealthy diet, lack of exercise, aging basically, which leads to increased ectopic fat deposition, and this ectopic fat deposition, it may be at the level of kidneys, visceral compartment, heart, muscles, brain, everywhere it causes dysfunction basically, and it leads to decreased metabolic rate, decreased physical activity, decreased anabolism, and there is setting of sarcopenic obesity basically. The fat basically as it grows, it loses its peripheral circulation, it becomes ischemic basically, and it generates inflammatory cytokines basically. So your good cytokines like adrenomycin go down, and your inflammatory and bad cytokines basically crop up, and it leads to increased incidence of cardiovascular disease, cancer, diabetes, fractures, and frailty. Now screening is very important. Once you screen, then you diagnose, and then you have to stage. The staging is that if there are no metabolic, no complications, then it is called as mild sarcopenic obesity, and if there is presence of complications, then it is a stage 2, that is severe sarcopenic obesity. It leads to higher frailty, disability, admissions, higher osteoporosis, higher prevalence of diabetes, hypertension, dyslipidemia, higher rates of depression, and higher mortality. So muscle mass is directly related, muscle mass and strength is directly related to all-cause mortality and other mortality. The cancers also go up. The major cause of cancers are obesity and sarcopenia. Now, good control of diabetes and concomitant metabolic disease is very important to address this issue. For the stiff man syndrome, you have to screen and assess strength, gait, range of motion and function limitations. Use musculoskeletal ultrasound MRI to identify fat infiltration, fibrosis, supported by visual imaging. You should institute early physiotherapy, focused physiotherapy with a multidisciplinary team approach, and with gradual rehabilitation these patients improve. Medical and pharmacotherapy, you should concentrate on weight loss you can achieve with diet and lifestyle and GLP-1 receptor agonist and bariatric surgery. But mind well, always weight loss with GLP-1 and bariatric surgery is associated with 30 to 40% muscle loss. And therefore, adequate nutrition and exercise is very important if you are to institute this therapy. Exercise consistency is better than intensity. You have to go for more than 2 episodes of resistance training per week. Aerobic activity, combined exercise have more benefits. Functional training focused on balance and mobility enhancement. Individualized exercise programs are essential. Regular physical activity promotes overall health, and you have to monitor the progress also. So you have to start with flexibility, exercise, balance training, gradually start with aerobic exercises, then resistance exercises. So you have to be very gradual, otherwise the patient has injury, then you will end up with problems basically. You have to go for a hypocaloric diet with adequate protein supplementation, adequate vitamin D supplementation, and adequate supplementation of calcium basically to address because once you lose weight, you should not lose muscle. To preserve muscles, you have to have adequate amount, and the recommended amount of protein is 1 to 1.2 gram per day. You should give more proteins if the patient is elderly, because there is a state of anabolic resistance in these conditions. And you can say this study also says that 1.2 gram protein is adequate. Leucine and essential amino acids, very important to drive the protein synthesis. This is a sort of metabolite of leucine, which is better, and as far as the anti-catabolic effects are concerned. Creatine supplementation, very important, because it increases the muscle energetics. Omega-3 fatty acids, anti-inflammatory effects, and useful. Antioxidants also very useful. Other factors are sleep, at least 6 to 8 hours of sleep. Otherwise, you will have sarcopenia. If you have circadian rhythm disturbances, then your stress hormones go up, and your muscle loss is there, and increased visceral fat is there. Smoking and alcohol, bad for sarcopenia. You should quit it. You should not advise the patient to initiate alcohol if he is taking, or has to limit down. Stress and cortisol again cause sarcopenia. Gut muscle acid, gut dysbiosis also causes sarcopenia. Coming to the drugs, metformin is very important. It has mixed human data. It may reduce age-related inflammation, improve muscle sensitivity in those patients who are doing exercise, and studies suggest potential benefit. However, it may impair adaptation to resistance training because it inhibits mTOR basically. So the data is mixed. SGLT2 and DGLP cause weight loss and should be supplemented with exercise. DV4 and thiazoles improve the insulin sensitivity, improve anabolic resistance, are good. Sulfonylurea is not good for addressing sarcopenia. Insulin basically is a anti-catabolic hormone, and if you keep the sugars under control with insulin, it helps sarcopenia. Testosterone should be given for those who have hypogonadism, should not be given randomly. SARMs that have less side effects are these hormones only, but await regulatory approvals. The growth hormone, IGF, ghrelin agonist, they increase lean muscle mass but do not improve function and have high side effects. These all should be given where there is a deficiency. Estrogens may preserve muscle mass in postmenopausal women, but not first-line drugs. ACE inhibitors are repurposed drugs basically. Emerging trials are myostatin and activin pathway inhibitors, and these are under trial. Bimagrumab along with semaglutide is being tried, but these medicines are shown to improve muscle mass, but muscle strength and muscle function, they have not shown to be improved. Senolytics basically improve autophagy basically, and neuromuscular electrical stimulation stimulate type 2 fibers and can be used in elderly patients where there is it reduces disease atrophy basically. So elderly patients you can use who cannot exercise properly, and gene therapy is under investigation. So key findings and conclusions: sarcopenic obesity is a rising global health issue due to aging and obesity trends, strongly related to higher risk of CVD fractures, disability and mortality. Main drivers are inflammation, insulin resistance, oxidative stress and hormonal dysregulation. Best treatment approaches: combined exercises, high protein diet, emerging and other essential vitamins, amino acids. Emerging pharmacological treatments need further research, further directions, developing standardized diagnostic criteria, understanding long-term treatment outcomes. Thank you very much.